This is Dr. Christopher Sendy with Nova Health Recovery Ketamine Infusion Center. I'm going to discuss ketamine therapies for chronic pain. And I'll be covering basically some of the mechanisms of chronic pain and how ketamine can help out with that. And then certain types of pain syndromes like CRPS, chronic regional pain syndrome, fibromyalgia, and headache disorders as well, and a few other things. And we'll kind of discuss some of the options for treatment using ketamine therapies. And pain is important for sensing and processing noxious stimuli or painful stimuli and responding to them. So when you injure an extremity, you pull it back and you protect it afterwards. And basically, there are peripheral and central mechanisms to modulate the way that we are sensitive to these types of stimuli. And it's a dynamic process. So in other words, an acute injury basically is something that we would feel immediate pain for, and then try to protect that extremity from further injury. But whenever that area heals, continued pain serves no purpose. And so chronic pain is what that's all about, and that's a dysfunction of the nociceptive or painful system. And when it negates pain as a marker of immediate injury, meaning that when there is pain but there's no injury, then that's chronic pain and it serves no purpose. And there could be central changes or modulation of pain perception that occur to produce this. And part of that is due to changes in the descending networks in the central nervous system that inhibit us from feeling pain. So in other words, we have central systems that basically work downwards to prevent us from feeling pain from the periphery. And the areas of the brain in particular are the rostro-ventral-medial medulla, which modulates the experience of pain by basically changing traffic to specific areas. And that can be damaged or changed or altered in chronic pain. And pain medications enhance the effects of this modulatory circuit basically at the spinal cord level. So when we look at the spinal cord, this is just a very basic example. The backside, the dorsal root ganglion, is up here, and the dorsal root comes from this area where there's basically the sensory portions of our dermatomes, which are entering through here. And this is basically just a representation of the spinal cord. And of course, the idea behind this is that basically the brain and the spinal cord all play a part in the modulation of pain. But even deeper than that are Nmda receptors. And Nmda receptors are located throughout the brain and the spinal cord. And they basically function as receptors for glutamate. And glutamate is a neurotransmitter that is involved with everything from learning to pain perception. And what the Nmda receptor is basically it is a receptor that has 4 subunits. It's got 2 N1 units and 2 N2 units. And there's different types of N1 and N2 units. So there's a lot of different Nmda receptors. And basically it's a non-selective calcium and sodium channel. It is ionotropic, meaning that when it opens, it allows ions like sodium and calcium to enter into the intracellular space. So basically, we have signals that come from the presynaptic neuron, the neuron before that's sending a signal to a postsynaptic neuron. And in the middle, we have a synapse. And the synapse is where all the neurotransmitters get exchanged. And on the postsynaptic neuron, we will have these Nmda receptors. And also we have AMPA receptors. Now, AMPA receptors also are responders to glutamate. And they will open up immediately with glutamate. They're very easy to get open, and they allow some depolarization of the postsynaptic neuron. And by depolarizing this neuron, if it gets high enough, then this will cause basically the allowance for the Nmda receptor to depolarize or open up whenever glutamate binds to it. And glutamate works with glycine. So glycine has to bind as well to its special site as well as glutamate. And the reality is that when the intracellular space depolarizes, there is a magnesium atom in the channel of the Nmda receptor that basically gets kicked out, and that's what allows the opening of the Nmda receptor. Once that happens, sodium and calcium flow in. The calcium then allows for intracellular a chain of events to occur to create proteins and do a number of other things, including ultimately mediate pain, for example. So neuropathic pain results from basically lesions of our somatosensory nervous system, which is basically where we feel pain from the periphery. And it causes alterations in the structure and function of those areas so that pain starts to occur spontaneously. or basically random shooting pains without any injury. And also responses to small amounts of pain begin to be amplified. So a small pinprick begins to feel like a hammer hitting you in the head. And then there's also various neurochemical processes that lie at the basis of the complex transition from neuronal damage to chronic neuropathic pain. And this causes basically peripheral and central sensitization. And this ultimately manifests itself as symptoms such as allodynia, where soft things feel sharp or burning, and hyperalgesia, where small pains are basically amplified into big pains. And then also temporal summation and spontaneous pain, where you get these shooting sharp pains suddenly without any reason for them. And so basically what's really going on is there's phosphorylation and upregulation of the NMDA receptors, meaning that they are increasing in their numbers and their activity and their ability to depolarize. And then there's also loss of the descending inhibition of the central nervous system over the peripheral nervous system. And then we start to get plastic changes in the spinal cord, meaning neuroplastic changes, where the neurons actually reroute, and also inflammation changes in the central nervous system and spinal cord, where immune cells start to release pro-inflammatory cytokines. Now, sensitization is basically the prolonged yet reversible increase in excitability and synaptic efficacy in nociceptive pathways triggered by nociceptive stimulation. So basically, as you get a small pain signal peripherally, you get increasing amounts of pain. There's sensitization. And again, we discussed allodynia and we discussed hyperalgesia, where there's just basically increased pain response to small pains. And central sensitization is actually a result of synaptic plasticity and altered ion channel kinetics of the NMDA receptors, as well as increased densities of those very same NMDA receptors and activated kinases in both the pre and post synapses. And this all results in amplified pain signaling, which causes chronic pain. So NMDA receptors are a key component of a lot of this process, and ketamine is involved as a basically antagonist of this particular receptor, and that's why it works so well. NMDA is the receptor is basically a glutamate receptor, as we mentioned earlier, and it's present all throughout the spine and the central nervous system. And basically, with upregulation and activation, we get basically amplified trafficking of pain signals, both centrally and peripherally. So when ketamine comes into play, basically it halts this excessive barrage of nociceptive input to the brain. In other words, it decreases the amount of pain signals that go to the brain. And that basically, this allows us to kind of modify, how we feel the pain. So we do get basically, again, significant results, especially in neuropathic pain with ketamine. Now, acute pain relief can also be induced by inhibiting the presynaptic spinal dorsal neurons and the dorsal horn neurons, which we showed earlier. And there's NMDA receptors at these presynaptic sites that, when they're activated, they actually enhance excitatory substances like glutamate and substance P. So basically, excess glutamate, which is sometimes seen in excess pain and chronic pain, activates NMDA receptors in the dorsal or back part of the spinal cord, the dorsal horns, and there's increased release of glutamate and substance P, which increases pain. And ketamine is able to influence this, as well as the top-down control of inhibitory pathways that stop this from happening. So basically, chronic pain patients frequently have a defect in their ability to engage the descending inhibition of pain. And so that said, ketamine functions on a number of different levels, both at the NMDA receptors locally and also the ability of pain to reach the central nervous system so that we can actually register it. And when you basically do functional MRIs, it was observed that low doses of ketamine in individuals who are getting functional MRIs in specific areas demonstrates activation of specific areas of the brain involved with pain, and the anterior cingulate cortex, and orbitofrontal cortex, and insula, which are involved with basically decreasing pain by sending signals to prevent pain signals from coming upwards. So they have descending inhibition of pain. Now, neuropathic pain patients with small fiber neuropathy, which is basically end terminals of the nerves as they go into the skin, for example, low dose ketamine can enhance certain pathways, something called conditioned pain modulation. And what this is basically it's the central inhibition of a focal stimulus by administering a second noxious stimulus at a remote area. So basically, pain inhibiting pain. So if you have one area that's causing pain, if you put pain somewhere nearby, it can inhibit that primary pain focus. And without ketamine, it was found that there was no conditioned pain modulation in patients with chronic pain. But when you gave ketamine treatment to individuals with a small fiber neuropathy who did not have conditioned pain modulation, they then developed it. And so this is felt to be one of the ways that ketamine works, as well as by increasing the magnitude of CPM activation. There is some evidence that the duration of ketamine infusions also determines the duration of an analgesic effect. So when we're treating pain in individuals, the longer a ketamine infusion goes on, the more enhanced the response is for the pain relief. So there are examples, and we'll actually hit these up shortly as well, but treating CRPS type 1 patients with 100-hour infusions of S-ketamine, as Sigtermans did in a study, demonstrated longer-term pain relief than shorter infusions, and it went up to 3 months. And Schwartzman as well did a study with CRPS demonstrating daily 4-hour infusions for 10 days worked better than shorter infusions. So basically, multi-day infusions frequently are needed for some of the more neuropathic pain components. And this has to do with not just the acute effects of ketamine, but probably the neuroplastic and anti-inflammatory effects. And the other aspect is that we do require retreatment with a lot of these pain conditions. So basically, the majority of the time there will be a relapse, and retreatment might be required, like in 4 to 6 weeks, for example. So there's no basically preemptive effect of ketamine on the development of chronic pain postoperatively. So if you, for example, are going to take an extremity off for ischemic pain, using ketamine ahead of that surgery does not decrease the episodes of chronic pain. And so basically, it's best to treat chronic pain and pain with a multimodal effect. And administering ketamine with opioid analgesics and other therapies is the best aspect of treatment when it comes to pain and chronic pain. And ketamine definitely improves the efficacy of opioid treatment in cancer pain, and it can reduce neuropathic pain better than opiates, and thus it works better in patients with cancer and neuropathic pain. There is a synergistic, meaning additive effect of ketamine with opiates, and it's because of the effect on the descending inhibitory pathways that prevents, and also the prevention of opioid hyperalgesia. And that's where basically increasing doses of pain medication and opiates can actually increase your sensitivity to pain. And so the very substance that you are leaning on, which is the opiates like morphine, to help you out with pain, is the very substance that makes your pain worse. And then there's also the antidepressant and anti-inflammatory and neuroprotective effects of ketamine as well. And there are studies demonstrating that as well. There is pathways of depression and pain that go hand in hand. So you can improve somebody's depression, you can improve their pain, and vice versa. So we discussed earlier that the NMDA, the N-methyl D-aspartate receptors, especially the NR2B unit, is a central component of increased excitability in chronic pain. And that basically the components, the subunits of the Nmda receptors actually change in patients with chronic pain, and increases nociceptive or pain signaling. And the NR2B subunit in particular tends to increase. And so individuals basically change the way that their NMDA subunits are evolved, and they begin to be more sensitive in that fashion, as well as being more numerous. So more NMDA receptors, and also the subunits are more sensitive to glutamate signaling. So basically, again, a common theme here for chronic pain is increased sensitivity irrespective of the initial physiologic assault. So the initial physiologic assault could be a pinprick, or it could be a fire, or it could be getting hit by a car. But basically, irrespective of that, chronic pain basically is an end pathway and increased sensitivity to any pain afterwards. So in chronic conditions like mixed neuropathic pain and complex regional syndrome, and also phantom limb pain, ketamine is an effective long-term treatment option. This is based on study, and actually a review by Cohen and all their colleagues in 2018. And then there's further systematic reviews demonstrating ketamine's use for a number of other conditions. And we're just going to kind of go in non-specific fashion here. Pestrak evaluated the systematic use of IV ketamine for fibromyalgia. And basically, the studies that they looked at suggested that the total dose of ketamine with longer and more frequent infusions may be associated with more effective pain relief and longer lasting analgesia. And that the low threshold of pain is caused by central sensitization and disordered pain regulation in the spinal cord and supraspinal levels, meaning in the brain. And that basically there's increased reactivity of pain processing cells in the spinal cord that results in hyperexcitable pain pathways and decreased activity of inhibition pathways that come from the top down. And so basically, they also have discussed how peripheral sensory neurons and axons show synaptic remodeling in the spinal dorsal horn, which is the area that we showed earlier, all dependent on activity of Nmda receptors. And so effectively, when they look at patients with fibromyalgia under functional neuroimaging relative to normal individuals, they showed a higher brain activation in key areas of the brain from all these changes, like the thalamus and the somatosensory cortexes and insula. And basically, they found these areas lit up with pressure, heat, and painful stimuli. And they also, in fibromyalgia patients, had an impairment of descending inhibitory pain pathways, and they had decreased activation of the anterior cingulate cortex. So basically, there's a significant imbalances in connectivity within the pain network at rest, and that there's changes in the way that we perceive pain and also the connectivity within even the spinal cord. And so some of the clinical treatment that increases serotonin and norepinephrine levels in the spinal cord has been found to be helpful in restoring descending inhibitory activity in fibromyalgia. So the potential of ketamine to enhance basically the internal pain systems results in basically increased descending serotonergic inhibition pathways. So that's one of the ways that ketamine works to basically increase the function of our descending inhibitory pain pathways is by increasing the serotonin levels. But also ketamine may reduce substance P in the nervous system as well, which is again something that causes pain when it's elevated, and also restore brain-derived neurotrophic factor so that the synaptic plasticity can return to normal. The anti-inflammatory effect of ketamine also is very modulatory in terms of decreasing the inflammatory mediators that also have a role in fibromyalgia. And so this combination of effect on Nmda receptors and functional changes in neuroplasticity basically may result in decreased chronic pain. So the systematic review by Pestrak and his colleagues in 2021 basically took 7 publications, 4 randomized trials using IV ketamine. And they had a total of 118 patients that they kind of included in these series of controlled trials. 106 were treated with ketamine. And they found that there was a short-term reduction in the self-reported pain intensity with 1 low-dose IV ketamine infusion. And that these individuals had both decreased pain and pressure hyperalgesia, increased pain tolerance at pressure points, and also decreased random pain. And so ketamine was able to reduce the increased pain, the hyperalgesia, from peripheral pain-dependent sensitization. And so effectively, there was decreased pain in these individuals. But basically, these case studies demonstrated that the higher the dose of ketamine given, the longer the duration of infusions, and the more frequent infusions produced the higher degree of pain relief and longer lasting analgesia. And so we've kind of reviewed the physiology of Nmda receptors and basically the aberrant signaling of downward inhibition pathways that occurs in chronic pain, and the upregulation of Nmda receptors and their changes in subunits, and also the neuroplasticity that results. And these all are the reason why ketamine is so effective, because ketamine hits all these areas. And so basically, with further evaluations of ketamine in a number of other trials and just case studies, it was found the same thing, that the higher the dose of ketamine that is administered during an infusion, that is a primary factor of basically clinically meaningful short-term analgesia. And a lot of this is linked to just the pharmacokinetics of ketamine. So Hannah and Smith administered IV ketamine to a patient with fibromyalgia over 4 hours at doses from 200 to 800 milligrams over 5 days. And they gave a booster of 800 milligrams 2 weeks later, and they ended up with long-lasting remission from chronic pain and improved quality of life. And another case as well with Hannah and his group basically demonstrated that fibromyalgia in a patient with rheumatoid arthritis who was given escalating doses all the way up to a gram with 10 consecutive ketamine infusions had meaningful decrease of pain as well. And then he had to get as well booster infusions every 3 months with the same dosing. Earlier studies also demonstrated that basically ketamine was able to increase the pain thresholds of fibromyalgia patients. In one study by Sorensen, 1995, 11 female patients received ketamine infusion of 0.3 milligrams per kilogram with a significant reduction in pain intensity scores. And most of the pain lasted from 2 to 7 days. And there were a number of different domains that were helped with this, including things like tenderness was decreased and increased muscle endurance, as well as decreased pain threshold. CRPS is a horrible neuropathic condition. It's chronic regional pain syndrome. And patients with this will present with pain in an extremity or extremities following trauma, and they get concurrent changes in sensory, motor, and autonomic and trophic domains. And so there are two different types, CRPS type 1 and type 2, which I'll go over shortly. But individuals who tend to suffer more are middle-aged women, and the upper limb is probably the more common extremity that's affected. And when people get injured, there can be 2 phases leading up to the CRPS. One phase is the warm phase, which is the classic phase of inflammation, where the person's extremity would be red, hot, and just warm and increased pain and inflammatory. And then a second cold phase where the individual's extremity atrophies, and there's changes in the skin and the subcutaneous tissues that just disappear, and even the muscles, and then there's osteoporosis. And a number of pharmacological treatments have been used with varying success, like biphosphonates and steroids and vasoactive mediators, as well as physical therapy. But this syndrome has both sensory, motor, and autonomic with trophic changes, and it can lack a clear dermatomal or peripheral nerve distribution, meaning it can just go all over the place, and so it doesn't follow one particular nerve pattern. So CRPS1 is basically somebody injures a specific extremity, and then basically that extremity develops a extended problem with further changes elsewhere. It's associated with edema and changes to the skin and abnormal blood flow and sweating or lack of sweating and just allodynia and hyperalgesia. And it's a common, CRPS type presentation. CRPS type 2 also is occurs after a partial injury of a nerve or a major branch. And this one, basically occurs, let's say, extremity or a foot. After somebody gets injured in that particular area, you can get redness and burning and pain and atrophic changes, and then it just goes from there. So sometimes CRPS 2 can evolve into type 1, but that said, again, there's ways to diagnose CRPS type 1 and type 2 based on specific criteria. So ketamine therapy for CRPS is, again, a evolving strategy of treatment. And there are 3 pain societies that recommend IV dosing of ketamine for chronic pain, somewhere between 0.5 to 2 milligram per kilogram for 1 day outpatient or 3 to 5 day inpatient treatments. And of course, inpatient treatments are not exactly convenient. And so a lot of clinics are offering the 5 and 10 day infusion therapies, and at moderate to high dosing, not anesthetic dosing. And that's in most of the time it's escalating doses. But the guidelines, again, are variable, and the clinical patterns and use of ketamine are definitely variable as well. But the idea is to get as long of an infusion and as high of a dose as possible, and that leads to better outcomes. So how does ketamine help pain in CRPS? And the primary way is, again, is ketamine blocks the Nmda receptors in the central nervous system. And this is one of the causative agents of CRPS. And it decreases, by doing this, the channel opening of the Nmda receptor and the amount of time that it's spent in the open state. And basically this decreases the excessive firing of painful nerves. But also ketamine can promote GABA signaling as well, which also can enhance descending modulatory pathways to decrease pain input. So there's a systematic review by Chetneni in 2021 on ketamine infusions for CRPS. And in these systematic review, they evaluated multiple studies and showed basically using escalating titrated doses were certainly helpful. And they looked at 9 studies that used the same dose throughout the duration of the intervention, and other studies that had escalating doses of ketamine infusions, anywhere from 5 to 10 days based on the dose of ketamine and the time of length of measuring in each study. Each one of those varied, but they basically found that most studies tailored ketamine on the individual's weight with doses from 0.15 to 7 milligrams per kilogram per hour. And then there were some that just used standard doses between 10 to 200 milligrams per hour. So the dosing strategies were all over the place. Some were static, some were escalating, and some were just like, this is the number you're going to get, and let's give you as much as we can. And 14 studies were evaluated in total. And basically patients who reported the best outcomes basically had the higher doses. And so a majority of the 14 studies produced positive results for the effect of ketamine infusions on overall pain control and function. And this basically was based on medically validated scoring systems. And a lot of them did have increased quality of life and positive changes in physical and cognitive functioning. And so again, there were some positive results with this, but the thing was is that there were multiple doses, multiple escalating doses, and multiple periods of time that were used. And Sigdermans also evaluated CRPS type 1 with ketamine therapies and found effective and long-term pain relief with doses of ketamine that he utilized in 60 CRPS 1 patients in a double-blind randomized placebo-controlled trial. And basically these individuals had a diagnosis of CRPS and had failed multiple other therapies, and including conservative therapies, physical therapy, medications, and they were all given ketamine infusions as a 4-day protocol with a dose of 22 milligrams per kilogram over a period of time. And the subjects were basically evaluated on their pain scores over the 12-week study period. And what they showed was patients receiving ketamine had significantly lower pain scores than patients receiving placebo treatment. And that although significance was established in the ketamine group, that by the 3rd month, there was really no difference between the ketamine group and the placebo group. So you're going to need to do repeat dosing or maintenance therapy, effectively, is what this is saying. And so, again, although you get short-term results with ketamine infusions, you have to expect that there's going to be continued therapies. And there are outpatient studies with CRPS treatments. Kirkpatrick in his group and Schwartzman in Kirkpatrick's group, their ultimate findings were basically that 4 days of outpatient treatment could treat lower extremity CRPS, but more than 4 days may be required for upper extremities. And so with Schwartzman's group, his individuals had CRPS pain for more than 6 months. They had failed conservative therapies, and they were infused for a 10-day period of time. And what they found was the IV ketamine group had a reduction in their pain parameters, while the placebo group showed no treatment effect. And they used pain questionnaires to evaluate the individual's response. And so during the entirety of the 12-week treatment course, there were decreases in pain parameters. And they found that there were decreased burning pain, decreased allodynia, and overall pain levels in the ketamine group during that 12-week period of time. And there's also some studies on subanesthetic ketamine infusions for the treatment of children and adolescents. But this study included both CRPS and other chronic pain syndromes, including headaches. They used 63 children who received IV administration of subanesthetic doses of ketamine in an outpatient setting in doses from zero point 0.1 to zero point 0.3 milligrams per kilogram per hour, and it lasted for 4 to 8 hours per day. And they basically evaluated the changes in pain scores. And they found that the best ketamine effects were those with CRPS versus other chronic pain conditions in children and adolescents. Now, Patil and Anetscu in 2012 also did a retrospective analysis on outpatient ketamine infusions for refractory chronic pain syndromes. And they looked at 5-year retrospective analysis of outpatient ketamine infusions, and 50% of patients with severe refractory pain of multiple etiologies had pain relief for up to 3 weeks with minimal side effects after receiving a ketamine infusion of approximately 0.9 milligrams per kilogram. And all the patients had certain pretreatments, and then they received specific doses of ketamine. And of course, the type of pain they were treating was really variable, but effectively it was well tolerated, and it resulted in pain relief for CRPS and specific types of headache disorders. But again, it did require repeat infusions, usually every 3 to 4 weeks. So in a 5-day inpatient infusion for CRPS with R and S ketamine, and these are like anesthetic high-dose ketamine infusions, there was an evaluation by Goldberg and his group to look at the breakdown products of ketamine to see if they had any impact on the outcomes as well. And so they evaluated ketamine and norketamine and other downstream metabolites and felt they probably do have a role in the analgesic process of ketamine infusions. And what they did is they had an observational study, and they had a 5-day moderate dose continuous racemic ketamine infusion, and they measured the levels of the breakdown products of ketamine. They had 16 patients in this particular cohort and measured basically the concentrations of ketamine before the initiation of the infusion and several times throughout, and then evaluated the patients thereafter. And they found that the ketamine infusion resulted in significant pain reduction by the 2nd day, and it correlated with peak plasma concentrations, supporting the anti-pain properties of the drug. So again, the higher the dosing of ketamine, and at its peak, that's when the best pain relief happens with ketamine in complex regional pain syndrome. And again, that kind of goes to the fact that the higher the dosing of ketamine, ultimately the better the pain relief. Now, racemic ketamine, given as a 4.5-day infusion, was also studied with Gobel, and this was in 2015. Ketamine infusions can produce significant analgesia in CRPS patients as well, based on this study. It was an observational study using low subanesthetic doses of racemic ketamine, and they found 60% of the patients had substantial pain relief during the period, and that basically there was a period of time where patients did have pain relief, but then they started to relapse at a later time. Now, pediatric CRPS, as we mentioned earlier, can also be treated with ketamine. And again, going back to the Sheehy ketamine infusion study, it was found that individuals in this program that had specific findings, in particular POTS, or postural orthostatic tachycardia syndrome, and trauma, basically had the highest results when they had CRPS with those particular features, and that headache disorders were the features that had the lowest response to ketamine infusions. So again, CRPS does respond to ketamine, but a lot of the studies that were done included other individuals that had different pain conditions. So it's difficult to dissect out ultimate results, but when they did an analysis, basically ketamine given to pediatric and adolescent patients with CRPS and POTS and trauma responded the best to ketamine infusions. And then there's a study by Kiefer and the efficacy of ketamine for CRPS, in which basically they gave individuals, 20 of them, ketamine infusions in anesthetic doses over 5 days, and put them in the ICU and intubated them. And they found complete remission from CRPS at 1 month in all patients, and then in 6 months in a significant number of these patients as well. They found functional improvements in the ability to work and have normal activity and range of motion. So basically, by giving super ultra high anesthetic doses in the hospital, they were able to get significant responses. And even at 6 months, there was response. Now, Zhao also did a systematic review and meta-analysis, and the primary outcome was pain relief in their analysis of CRPS based on a number of different studies they looked at. And they felt that there was statistical significance, even though there were a lot of heterogeneous studies involved. And again, we've already mentioned that most of these studies are all over the place. They found immediate pain relief in 70%, and that basically the pain relief event rate at 1 to 3 months was about 60%. So in the short term, for at least less than 3 months, ketamine infusions can provide significant and effective pain relief. But after that, you're still going to need repeated infusions. Now, after all this ketamine, what happens to your ability to think? Well, Koffler evaluated this in 2007, and after a 5-day anesthetic ketamine infusion for CRPS, they found that individuals basically had no adverse cognitive effects. And basically, there was no changes in mood or personality factors because the dosing was very high. But again, there was no cognitive effects from these types of ketamine infusions. Now, ketamine has also been used for headache disorders. And so IV ketamine for the subacute treatment for refractory chronic migraine, the case series, was evaluated by Lauritsen in 2016 using a retrospective chart review, and 0.1 milligrams per kilogram per hour and increased by a specific amount until basically the patient had a 3 out of 10 target pain, and then they continued on for 8 more hours of ketamine infusions. And this treatment was associated with short-term improvement in pain severity in the patients, 6 out of 6 with refractory chronic migraine. So again, escalating doses of ketamine for chronic refractory migraine can certainly be used. And cluster headaches also have the ability to be treated with ketamine. Now, certainly IV formulations, but intranasal formulations in particular can be effective. And Peterson in 2022 took 23 patients and evaluated them by using 15 milligrams of intranasal ketamine every 6 minutes, up to 5 times. And 30 minutes after the first application, the pain intensity was reduced by 60%. And basically, the intranasal ketamine was effective in the treatment of cluster headaches. There's also a mixing of lidocaine and ketamine infusions for headache disorders. And Ray and his colleagues in 2022 evaluated 83 infusions, 50 of them were lidocaine, 33 were ketamine for headache disorders. And again, there were multiple headache disorders that were included in this, so it's a little difficult to tease out the actual data, but effectively lidocaine infusions achieved a greater than 50% reduction in pain. And as far as the ketamine infusions, there was certainly effectiveness as well, but lidocaine seemed to work better in this particular set of studies. And then as far as non-specific, unspecified primary headache disorders, the efficacy of ketamine in the treatment of migraines and unspecified primary headache disorders was evaluated in a systematic review by Cha in 2021, using 5 randomized controlled trials in 193 patients. Basically, they had found that there was one RCT, randomized controlled trial, that said intranasal ketamine was superior to a placebo of intranasal midazolam, improving the aura attack severity but not the duration. And then there was another trial included that showed that subcutaneous ketamine was superior to saline in migraine severity reduction. And the intranasal ketamine randomized controlled trial that was referred to was the one by Afridi. This was in 2013, where they used a double-blinded parallel group-controlled study using 25 milligrams of intranasal ketamine on migraine with prolonged aura in 30 migraineurs. And basically, they found that ketamine reduced the severity but not the duration of the aura in this group, whereas midazolam had no effect. So basically, in a further exploration of studies of ketamine and altering the Nmda receptors in migraine, Nicoldi in 1995 had even looked at ketamine infusions and also ketamine as a prophylaxis to basically prevent migraines. And they found ketamine produced a marked relief of pain, both as an acute therapy treatment and also as a prophylactic therapy. And then in the Journal of Anesthesia and Clinical Research with Moga Head. And this was in 2017. They looked at IV ketamine and lidocaine infusions for controlling refractory trigeminal neuralgia. It's a horrible headache, facial pain condition, which involves the trigeminal nerve on the side of the face, where there's sudden burning and shock-like facial pain, and it can persist from several seconds to several minutes. Opiates don't work very well with this, and they used 100 adult patients with trigeminal neuralgia, and they randomized them to receive either ketamine or lidocaine infusions. And they gave the dosing of ketamine and lidocaine infusions, and then this was performed consecutively every fourth day for 3 infusions. And they found that ketamine had a significantly longer duration of pain relief at 2 weeks, 1 month, 2 months, and 3 months, without serious side effects. And there was also a decrease in the carbamazepine use by patients on with the trigeminal neuralgia. So they used less of their baseline controlling medication that's typically used for trigeminal neuralgia. So ketamine does have efficacy for trigeminal neuralgia. And then in general for facial pain, which again is a wide variety of etiologies, Matheson looked at using ketamine in 1995 in 17 patients. And basically the experiences were best for those who had the shortest period of illness. And also those who had the greatest pain relief also had a short period of disease time prior, but some of them had also utilized oral ketamine and had effective pain relief with that as well. So you could also enhance ketamine's effects with dextromethorphan. There's a study where basically dextromethorphan at 90 milligrams per day demonstrated significant benefits in both the pain intensity results and diminished pain paroxysms, as well as extended pain relief for 1 month after individuals who had received IV ketamine infusions. And there was also benefits on cognition and quality of life. And then there's ketamine in spinal cord injury. And there is a study by Ammer and his group in 2016 or 2010, excuse me, in which 40 patients who had neuropathic pain from a spinal cord injury received IV ketamine infusion. And they also had received gabapentin, and the placebo groups received gabapentin as well. And what they demonstrated was significant pain score improvement in the ketamine group at a number of different time frames. And the multi-day low-dose ketamine infusion as an adjuvant to gabapentin in post-spinal cord injury-related chronic pain was safe and efficacious in reducing pain. The effect lasted for about 2 weeks. Now, no ketamine talk can be done without a little discussion about the misuse of ketamine. Ketamine does have popularity in recreational drug scene, but there is no physical dependence. There's no physical withdrawal state. And so, again, it's something which can be certainly misused and abused, but on the other hand, though, there's no withdrawal state from this. So in clinically monitored settings, again, ketamine is extremely safe. And again, it does have great efficacy in both pain and mood. So a summary of pain therapy with ketamine is effectively that the studies for pain are all over the place, and that the controlled trials include patients with pain that are from a number of sources. And so when it comes to CRPS, there's a number of studies that have escalating doses, static doses, and then there's also the duration of dosing that is variable, and then the total number of patients. So the majority of the treatments have been done actually just clinically. And generally speaking, a lot of these initial infusions for CRPS, for example, are done between 4 and 5 days in the office setting with escalating doses to try to get the maximum amount of ketamine over the maximum amount of time. And so we have discussed a couple of times now that ketamine infusions may be more effective for severe neuropathic pain when there's higher duration and higher doses utilized. But just recognize that maintenance is required, and that also that maintenance may require home use of intranasal or oral ketamine to prolong effects, and that things such as dextromethorphan may be helpful in the maintenance therapy after initial IV ketamine treatment. And definitely monitoring for appropriate use is extremely important.